بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. In this video I will talk about urinary tract infection. Urinary tract infection could be considered as a mild infection or maybe a severe infection according to the clinical manifestation the patient presented with. It may present with mild symptoms or it may present with severe manifestations concerning the complications of the disease like renal abscess, septicemia, acute kidney injury and chronic kidney disease, and this depends on the host and organism criteria and on the recurrence and the severity of the case. This picture shows different colors of urine. The urine analysis is considered a cornerstone investigation in renal patient evaluation and diagnostic approach through physical examination of the urine and chemical examination, including cells and casts and crystals that may indicate the diagnosis of the patient and further follow-up and further investigations needed for the diagnosis. Firstly, this is some questions in the concerning the topic of urinary tract infection. You can try to solve these questions, and we will solve these questions at the end of the presentation. I took the in my topic through this agenda: definitions, epidemiology, classifications, clinical types, and we will talk mainly in this topic about pyelonephritis, either acute and chronic forms. Firstly, we will discuss some definitions concerning this topic. Urinary tract infection can be defined as presence of bacteria or other microorganisms multiplying within the urinary tract and detected in urine specimens properly collected from a person with symptoms or signs of urinary tract infection with or without renal impairment. From this definition, the symptoms or signs should be present in the patient of urinary tract infection to fulfill the diagnosis, and also the renal impairment is not a must in this patient. The patient may present with renal impairment or without renal impairment, but it should be an evidence of urinary tract infection through the multiplying microorganism in the urinary tract through the urine analysis examination. Significant count, or what is called significant bacteriuria, is over 100,000 bacteria per milli urine. The urinary tract infection is one of the commonest bacterial infection treated in general practice and responsible for a considerable morbidity. Regarding epidemiology of the urinary tract infection worldwide, it is the most common bacterial infections affecting about 150 million people each year worldwide, and in USA it about 10.5 million office visits for urinary tract infection symptoms, and from 2 to 3 million emergency department visits. And of course this is an infection that costs the community and society either from the healthcare point of view and from the financial. The urinary tract infection may have serious sequelae that include frequent recurrences, sepsis, renal damage, preterm birth, and complications in a pregnant woman, either for the mother or for the fetus. And also, the urinary tract infection may result in complications that related to the treatment used, because antimicrobial use may result in high level of antibiotic resistance, especially if the patient will not complete the course till the end of the course or full course, or it may result in a Clostridium difficile colitis from recurrent antibiotic use from recurrent infection. Bacteruria means presence of bacteria in the urine. Significant bacteruria means presence of more than 100,000 pathogen per ml urine. Asymptomatic bacteruria means the presence of significant bacteruria without symptoms, and this may be present in a patient with an indwelling castor or persistent castorization or diabetic patients. Biuria means presence of 6 or more white blood cells per high power field of urine, and a positive result on gram staining of urine specimen, or a urinary dipstick test positive for a leukocyte esterase, which is an enzyme produced by the pathogen. The term asymptomatic bacteruria, this term means presence of significant bacteruria without symptoms. Previously, any patient with asymptomatic bacteruria was treated for this bacteria by the necessitated antibiotic. But after many trials and evidence, this handling of these cases was changed. Some patients should be screened and treated for asymptomatic bacteruria, and others shouldn't and need only follow-up. In the first category, which include patients that should be treated from asymptomatic bacteruria, this category includes pregnant women, prior transurethral resection of prostate, prior any urological procedure to prevent the dissemination of infection, and in women with catheter associated bacteriuria if bacteriuria persists after catheter removed. This group should be treated for asymptomatic bacteriuria. Okay, and this group should be treated because this will lead to decrease in the premature or low birth weight infants in pregnant women, and lead to decrease the complications that may result from this asymptomatic bacteriuria, because it may proceed to pyelonephritis, acute pyelonephritis, or chronic pyelonephritis after that. So the treatment here is important to decrease the risk of subsequent complications. The second category, which includes the patients that shouldn't treated for asymptomatic bacteruria, includes premenopausal non-pregnant women, diabetic women, older persons living in community, early institutionalized subjects, elderly institutionalized subjects, and persons with spinal cord injury. And this group shouldn't treated with antibiotics for this asymptomatic bacteriuria. because the treatment here will not change the sequelae, and there is no serious complications that may present in this group. And also the use of recurrent courses of antimicrobial in these patients will lead to antimicrobial resistance. The urinary tract infection could be classified either to uncomplicated or complicated group. Uncomplicated with normal urinary tract anatomy and normal renal function, and complicated if there is predisposing factor that may lead to a complication in this patient with urinary tract. The predisposing factors that lead to complications either anatomical or physiological predisposing factors. Abnormal anatomy of urinary tract include vesicoureteric reflux, obstruction, paraplegia, atonic bladder, chronic prostatitis, and diverticulum. And functional or physiological predisposing factors, all males considered a predisposing factor for complications if the urinary tract infection occurs. Impaired renal function, impaired host defense, neutropenia, immunosuppressive therapy, or patients with diabetes or organ transplant recipient, virulent organism like urease producing proteus species, or metastatic staphylococcal infections. These physiological or functional factors may lead to a serious complication in urinary tract infection. Females are highly susceptible for urinary tract infection because an anatomical reason, because the urethra is short and open through the vagina, negligence of urination for a longer period, pregnancy and labor and related maneuvers, and because of menopausal vaginitis that lead to mucosal atrophy. The clinical types of urinary tract infection, it could be classified either asymptomatic bacteruria or symptomatic, which is the typical manifestation or a typical group of urinary tract infection. And this symptomatic category can be classified according to the level and the site of urinary tract infection into lower urinary tract infection and upper urinary tract infection. Lower urinary tract infection includes cystitis, urethritis, prostatitis, and upper urinary tract infection includes acute and chronic pyelonephritis. A specific type of urinary tract infection is urinary tuberculosis, which leads to granulomatous infection, including kidneys, ureter, prostate, seminal vesicles, epididymis, and testes. This figure shows the two types of symptomatic urinary tract infection: upper urinary tract infection and the lower urinary tract infection. These are symptoms of lower urinary tract infection, categorized in 3 categories: either voiding symptoms, including weak or intermittent urinary stream, straining, hesitancy, terminal dribbling, incomplete emptying. Storage include urgency, frequency, incontinence, nocturia, and postmicturition, dribbling. Strangury. The strangury is a symptom that include a cluster of manifestations. It is a painful micturition in which the urine is emitted drop by drop, accompanied by severe sense of urgency and with residual feeling of incomplete emptying. So it includes 3 symptoms: urgency, incomplete emptying, and dysuria. And this is attributed to the irritation of urothelium of the urinary bladder, and it may present in bladder stones, cystitis, and bladder cancer. The concern of our topic is Pyelonephritis. We'll talk in details on pyelonephritis, acute and chronic. Pyelonephritis defined as microbial infection involving renal pelvis and renal parenchyma. Byelitis infection affecting mainly renal pelvis. Pyelonephrosis is a different term that should be differentiated from pyelonephritis. Pyelonephrosis means infection on top of previously present hydronephrosis or back pressure on the ureters and kidneys with collection of urine. Urinary tract obstruction leads to collection of white blood cells and bacteria and debris in the collected system. Similar to an abscess, pyelonephrosis is typically associated with fever, chills, and flank pain, although some patients may be asymptomatic. Risk factors for the development of pyelonephrosis is immunosuppression and any anatomic urinary tract obstruction, either stones, tumors, uretero-pelvic junction obstruction, or congenital abnormalities in kidneys like pelvic kidney or horseshoe kidney. The causative organisms in acute pyelonephritis include bacterial and non-bacterial microorganisms. The bacteria, mainly gram-negative bacilli, more than 90%, is E. coli. Also in this group, Klebsiella, Enterobacter, Proteus, and Pseudomonas. Gram-positive cocci include Staph aureus, Streptococcus faecalis, and Streptococcus hemolyticus. Non-bacterial organisms include fungi like Candida, Chlamydia, and viruses. Also, in the etiology, we should mention the routes of infection and the predisposing factors that lead to acute pyelonephritis. The routes of infection may be ascending infection directly from the skin, or lymphatic route through lymphatic system from colon, for example, or hematogenous or distant spread of bacteria, like in case of infective endocarditis, pneumonia, or septic foci in the mouth or pharynx or dermal septic foci. Also predisposing factors like we discussed before in complicated and uncomplicated urinary tract infection may be anatomical causes or physiological causes that lead to this acute pyelonephritis. Anatomical causes like any causes of obstruction, stones, neurogenic bladder, transmission of infection through catheter or cystoscope, immunosuppression, which affects the function of the immune system and host defense mechanisms like extremes of age, diabetes, malignancy, any patient receiving immunosuppressant medications, and pregnancy due to decreased ureteric peristalsis, and there is back pressure on the kidneys, especially in the right kidney, by the gravid uterus, which predispose the urinary tract for the infection and pyelonephritis. Symptoms of acute pyelonephritis include general symptoms like any infection, fever with rigor, headache, malaise, sweating, and fatigue. Local symptoms in the loin, which is the site of the kidneys, acute loin pain, and also may radiate this pain to the groin. In addition to lower urinary tract manifestations like frequency, dysuria, strangury, if the infection propagated from the kidney to the lower urinary tract, and also GIT manifestations including vomiting, nausea, and diarrhea. Signs of acute pyelonephritis include fever, tachycardia, sweating, tenderness, and rigidity in the renal angle over the affected kidney. And also we should mention in the clinical picture the complications that may result from acute pyelonephritis, which include perinephric abscess and pyelonephrosis, lower urinary tract infection, septicemia, impaired renal function, and acute kidney injury, or recurrence of this urinary tract infection and acute pyelonephritis that may lead to, at the end, renal scarring and chronic kidney disease. And these are stages of urinary tract infection, from colonization to the acute pyelonephritis and acute kidney injury at the last stage. The term of acute necrotizing papillitis or acute papillary necrosis is a serious complication that may result from acute pyelonephritis, but there is also other causes that may lead to acute necrotizing papillitis other than acute pyelonephritis, and these causes include diabetes mellitus, tuberculosis, analgesic nephropathy, obstructive uropathy, vasculitis, and sickle cell anemia. The mechanism of necrotizing papillitis in these diseases, including acute pyelonephritis, the infection, if it is a severe form, will cause thrombosis of blood vessels supplying the papillae, causing their necrosis and sloughing. The necrosis and the sloughing of renal papillae will lead to severe hematuria, and this sloughed soft tissue that will appear in the urine and urine analysis will lead to necroturia and urinary tract obstruction with this fleshy masses or cells that will obstruct the urinary tract, and lastly acute kidney injury. Investigations that we need to diagnose the urinary tract infection and acute pyelonephritis. Firstly, and the first investigation, as we said in the beginning of the presentation, is the urine analysis. It's very important to use urine analysis in the diagnosis of any renal disease as a primary investigation. The urine analysis may be turbid or normal in acute pyelonephritis according to the severity of infection. Fishy smell may be present with Escherichia coli. Ammoniacal smell may be present with Proteus. Proteins may be present but mild, 1 plus. Nitrite may be positive. pH may be acidic in E. coli or alkaline in Proteus infection. Microscopic examination in urinary tract infection, to say the patient has urinary tract infection, it should has pus cells or white blood cells and other evidence that there is an infection with a foreign microorganism in this patient. Pus cells is a very important finding in urine analysis, or white blood cells, and according to its count I can consider the severity of the urinary tract infection. Few RBCs, epithelial cells, and bacteria itself could be identified in urine analysis. Casts of the acute pyelonephritis is called white blood cells casts, and also hyaline and epithelial casts may present. The second step after urine analysis that I should do is urine culture and antibiotic sensitivity. The importance of this step is the identification of the sensitive antibiotic for this type of bacteria. I should recognize the bacteria that led to this infection, and after recognition of this bacteria I should know which antibiotic will affect and treat this bacteria. So a sample of urine should be midstream with aseptic collection. Count of bacteria is important to differentiate infection from contamination. So the significant count is more than 1 100,000 per milli, which is significant bacteriuria. And this is a demonstration of how the urine culture and sensitivity is done. There is in each plate of the culture there is discs. These discs demonstrates different antibiotics. Each disc of these discs demonstrate a specific type of antibiotic, either for example ciprofloxacin, ampicillin, cephalosporins like cefobrazone or cefotaxime. And when we put a sample of urine in this media of the culture, if the area of blanching or white area developed around the disc of antibiotic, this means the bacteria is sensitive to this antibiotic, and this antibiotic will affect the bacteria. And the other discs without a blanching around them, so this is resistant antibiotics for this bacteria. When we obtain a urine specimen, we should follow some important instructions. Specimens should be collected carefully and processed or refrigerated promptly. Specimens should not be allowed to sit out on counter to avoid aerobic infection, and about every 20 minutes at room temperature, causing false positive results. So it should be refrigerated if will not be processed once when it is received. Clean catch midstream urine specimen should suffice for diagnosis of urinary tract infection in older children and non-menstruating women and men. Castrized specimens are indicated in certain situations, such as patients who are unable to provide clean catch specimens because of urologic or neurologic problems. Investigations also for diagnosis of urinary tract infection, I should know sterile biuria term. What is meant by sterile biuria? Means pus with repeated negative culture. So there is pus in urine analysis and the pus cells, white blood cells, but when I do a urine culture, it will be negative for any organism, and I cannot define an organism in this culture. This may be found in specific types of infections that need specific media to grow on, or it may be in non-infectious causes of biuria, non-infectious causes that lead to formation of pus cells. The specific type of infections with specific microorganisms that need special media to grow, like tuberculosis or fungal infection. So on ordinary media it will not grow and will give us no result for specific bacteria. Also non-infectious causes like urolithiasis or urinary tract stones, analgesic nephropathy, and incomplete antimicrobial treatment of urinary tract may result in a negative culture if the patient was taking an antibiotic before the culture is withdrawn. So it may give us a negative culture, and because of this the patient should be advised to stop any antimicrobial or antibiotic treatment at least 48 hours before giving the sample for urinary for urine culture and sensitivity. At least the types of infections that lead to sterile bacteria and also non-infectious causes. Also, in the investigations of acute pyelonephritis, we need to do renal function test to assess the renal function, either if there is acute kidney injury or chronic kidney disease or normal function. CBC may show leukocytosis due to infection. Renal imaging detects signs of acute pyelonephritis and predisposing cause, and the complication, if present, can be detected by the renal imaging, either ultrasound or CT. And from this picture of ultrasound, we can manifest the nephromegaly or enlargement of the affected kidney with acute pyelonephritis, and also here this kidney enlarged when compared with the other kidney because of acute pyelonephritis and infection. Regarding the treatment of acute pyelonephritis, we have two steps of treatment: prophylaxis and specific treatment. The prophylaxis is needed mainly in cases of recurrent infections and when there is a non-treatable predisposing factors in patient, like patients who receiving immunosuppression, diabetic patients, old age patients with recurrent urinary tract infection. So we need this prophylaxis treatment to avoid the recurrence of urinary tract infection and acute pyelonephritis. It's called Urovaxone. The Urovaxone, it is like a vaccination against specific strains, about 18 strain of Escherichia coli. So it is like a vaccine against E. coli. It can be given once daily for 3 months at empty stomach, and this drug elevates the local immunity of urinary tract against infection by E. coli. Active or specific treatment of urinary tract infection and acute pyelonephritis include general measures and specific treatment. The general measures, like any infection, including bed rest, light nutrient diet, ample fluid or increasing the amount of fluid intake to dilute urine and wash out bacteria and pus. Symptomatic treatment including analgesics for pain, antispasmodics, antiemetics, and antipyretics if there is fever. The specific treatment including antibiotic according to culture and sensitivity, as we said before, and during the period we wait the result of culture and sensitivity, we could start a broad spectrum antibiotic to control the manifestations till the result of urine culture and sensitivity appear. These wide spectrum antibiotics include ampicillin or quinolones for 3 to 5 days till the culture result appear. Treatment of complications if present, like if there is perinephric abscess or pyelonephrosis, it should be treated with the specific measures according to the complication present. Regarding chronic pyelonephritis, this is a chronic form of pyelonephritis which lead to chronic interstitial nephritis regarding the pathology of the kidney caused by bacterial infection. The etiology is similar to that of acute pyelonephritis with the same routes of infection and predisposing factors and microorganisms that lead to infection, but this is the chronic prolonged form of pyelonephritis. It may be asymptomatic, discovered by routine urine examination with pyuria, proteinuria, or hematuria, or it may manifest with systemic manifestations of chronic pyelonephritis, and chronic kidney disease, including fatigue, body ache, weight loss, anorexia, abdominal pain, specifically loin pain, prolonged low-grade fever, hypertension, and anemia as a result of chronic kidney disease, with manifestations of hypertension and manifestation of anemia and other manifestations of kidney. The renal manifestations include recurrent attacks of loin pain, dysuria, pyuria, and fever, and tubular function also affected, leading to salt losing nephropathy and proteinuria, and also manifestations of predisposing causes if it present. The investigations also, starting with urine examination and urine analysis. Non-nephrotic range proteinuria may present due to chronic interstitial inflammation that present in the kidney. Nitrite positive, which is a product of bacterial metabolism. Cells, white blood cells, few RBCs, bacteria, white blood cell casts, hyaline and epithelial granular casts, and urine bacterial count and the culture and sensitivity can identify the specific type of bacteria and the sensitive antibiotic. Renal function test here should be evaluated if there is any impairment of renal function. We should order serum creatinine, blood urea nitrogen, estimated glomerular filtration rate, because usually it is impaired at this stage of disease because of chronicity and chronic interstitial nephritis. Tubular function is much more affected than glomerular function in this disease. Blood changes, normocytic normochromic anemia, leukocytosis, and elevated ESR. Renal imaging here may show small kidneys and irregular shape compared with acute form, which lead to enlarged kidney, but here in chronic pyelonephritis lead to small kidney due to recurrent infection and chronic interstitial nephritis that lead to small kidneys, and if it is present in one kidney, it leads to unequal size of both kidneys. Impaired renal function and predisposing factor may be present in renal imaging. Renal function can be evaluated by renal imaging through the renal technetium scan or renogram that give us an information about split renal function. It gives us the specific percentage of renal function of each kidney, either right kidney or left kidney. Renal biopsy rarely indicated and will show the histopathological pattern of chronic interstitial nephritis. This image of CT scan of the both kidneys, revealing the renal scarring and the shrinkage of the both kidneys and irregularities in the outline of the kidney due to chronic pyelonephritis, and here also one kidney affected by this chronic pyelonephritis with irregular border and shrinkage. And this image of technetium renal scan or technetium renogram that evaluate the split renal function of each kidney and give us a result of each glomerular filtration rate of each kidney. Here in this picture, the right kidney is 60% and the left kidney is 40%. And this image of renal biopsy of a patient with chronic pyelonephritis that lead to chronic interstitial nephritis, and we can notice here the invasion of the interstitium by chronic inflammatory cells, including lymphocytes, neutrophils, monocytes, and macrophages and plasma cells. The treatment also including the two stages of treatment, prophylaxis and treatment. Prophylaxis here is important to avoid the recurrent attacks and persistent infection, and to decrease the recurrent acute attacks on top of chronic disease that present with urovaxome also. And active treatment here, the same symptomatic treatment as before. And here we can add another item in active treatment, which is alteration of urinary pH that is important in chronic cases to prevent the persistent growth of the bacteria by changing the environment and media that encourage the growth of this bacteria. So if urine is alkaline and the bacteria grow in alkaline media, we should give the patient ascorbic acid 1 gram per day to change the urine pH to acidic media. And if the urine is acidic and this is the preferred media for bacterial growth, we should change the media to alkaline media by sodium bicarbonate 1 gram per day. A specific treatment also including antibiotic according to culture and sensitivity for antibiotics, and the treatment of complications if present. This patient present with CKD and different manifestations and the complications of chronic kidney disease should be treated like anemia, hypertension, and chronic kidney disease, bone and the mineral disorder. Lastly, at the end of the presentation, I will talk about an example of an infection that lead to a change of the urine color to an unusual and uncommon color, which is called purple urine bag syndrome. This is a urine bag that is turned to a purple color from the amber yellow color due to infection of this catheterized patient with an organism. So simply it is an urinary tract infection that need antibiotic treatment according to culture and sensitivity. Okay, this condition is most common in patients with permanent urinary catheterization, either urethral or suprapubic, in combination with a highly alkaline urinary tract infection. So it is an alkaline urinary tract infection. Numerous organisms have been reported to cause this syndrome, which is purple urine bag syndrome. Mainly, the main organism is Providentia strain or Providentia bacteria. Also, other bacteria can lead to this syndrome, including Escherichia coli, Proteus, and Klebsiella. These are the questions in the beginning of the presentation. If you solved it previously, we will demonstrate the results of these questions. Significant bacteriuria is the presence of the pathogenic bacteria in urine. Yes. If it is more than 100,000 microorganisms or bacteria per milli. Strangury means, what is the definition of strangury of these four options? Yes, it is D, painful micturition accompanied by urgency and the feeling of incomplete emptying due to urinary bladder causes like sites. Etiology of sterile biuria includes the following except which one of these causes not lead to sterile biuria. Yes, it is E. coli, because E. coli lead to biuria with presence of organism that can be identified by culture. And what is the type of this imaging technique that we talk about in chronic pyelonephritis, which give us the split renal function or a specific renal function of each kidney. Yes, it's called technetium renogram or technetium renal scan. Thank you.